Good afternoon to all my friends, and thanks to the Delhi Ophthalmic Society. I must say my regards to Dr. Grewal, Dr. Arul, and Dr. Kudlu here. My topic for the day is the Presbyopic IPCL, and I'll be glad to share my experiences with this particular technology. So I have no financial relationship with the product I'll be talking about, and nothing to declare here. So one of the earliest problems which we face as we are aging is the problem of losing near vision, which is presbyopia. And presbyopia has been the holy grail in vision correction. So let us see, is the presbyopic IPCL the solution for that? Is it the missing link between the corneal inlays, ophthalmic lasers, and prelex with multifocals? Does presbyopic IPCL, Phakic IOL actually fit the bill what we want from it? So the Phakik IOLs have a long history of being angle supported, iris supported, and lens supported. The lens supported Phakik IOLs have been here for a long time, nearly over 20 years now, and with innumerable implants all over the world. My interest is that this is a new tool for reversible presbyopia treatment in patients of presbyopic age. What are the options available? LASIK, prelex, and presbyopic IPCL. LASIK, as we all know, is a cornea tissue-based surgery. It does alter the biomechanics of the cornea, and for presbyopia may require multiple refractive zones, which may induce high-order aberrations. It is a non-reversible procedure on cornea in a lot of cases. The cost of the equipment, the stability of LASIK correction over time period, they're all questionable. Now, the other issue is that the Phakic IOL, whereas have no touching of the cornea, so there is no tear film alteration, no induction of dry eye, is possible in very large pupil sizes, no biomechanical weakness, and poses no risk for IOL calculations for a latter date if the patient does get a cataract. You don't need to use any different formulas. You can use multifocal and EDOFs for this patient at a latter date if he gets a cataract, whenever he gets old. No issues with the IOL, IOP measurement, no correction formulas required. Now let us come to the prelex. In prelex, are we cutting or removing a tissue which we could have saved? Issue with prelex are the issues with calculating power of IOL to be implanted in patients who have got a PRK or a RK or a LASIK done priorly. Also, in extreme refractive errors or extreme keratometry conditions, the IOL formula dependency is very high and there are chances of error. So the predictability of correcting a refractive error can be less if there is high astigmatism or high issues like that. The risks of prelex are, as we all know, like cataract surgery, endophthalmitis, capsule rupture, PCO, vitreous loss, unwanted photic phenomenon with a multifocal lens, increase in number of floaters. Excellent biometry is a cornerstone whenever you're trying to do a prelex or a lens exchange, and especially in post-refractive patients, that could be an issue. Whereas the Phakic IOLs have a long proven track record with more than 5 lakh implants, 20 years of track record, and with improved design and the long proven track record, the IPCL fits the bill. The best part about the IPCL is you are able to correct the patient's refractive errors, astigmatism, and presbyopia in the same go, and that also with a smart toric lens, which you don't need to rotate. Retaining the crystalline lens in an IPCL is advantageous because even the residual amount of dynamic state of this crystalline lens adds to the value of the presbyopic correction. The extreme powers available to correct the astigmatism and the refractive errors, along with the various choices of lenses, nearly 13 different sizes available in the IPCL and different optical sizes for different pupils, gives a large advantage over any other procedure, in my opinion. So let the numbers speak. We have a joint experience with a large number of IPCLs, multifocals, trifocals, with using the same technology from the same company. We've done more than 2,000 cases of IPCL, 17 cases of pure piggyback for post-pseudophakic, 8 cases of presbyopic correction with secondary and primary correction. Now compared with the experience with the multifocal IOLs using the same technology which is available in the presbyopic IPCL, we've done nearly 5,800 surgeries. 1,000 with the trifocal and nearly 4,800 with the bifocal. And we have excellent results, and with only 2 or 3 explants due to glares and halos, which means that the technology of diffraction used in these lenses, which is similar that used in a presbyopic lens, is amazing. So the accuracy of the trifocal, giving a complete range of intermediate, near, and distance is fantastic. Using a presbyopic IPCL will have the same contraindication what you would have for a normal phakic IOL: history of uveitis, corneal dystrophies, or if there is any presence of cataract, then you don't, of course, go for a presbyopic IPCL. You go straight for a prelex. It's a simple surgical procedure, no high-end surgical equipment, expensive equipment required. You just need a retinal and a cycloplegic refraction workup, similar as a simple regular phakic IOL. And you can start even putting this in previous pseudophakics which have been operated for you. The lens is available from 1.5 to 3.5 diopters of size. And the best part is it is also available to correct the previous myopia or hyperopia, along with the astigmatism, pre-existing astigmatism in these patients. Now, these are a few images from some of the cases operated. Now, this is again one of my favorite situations where I've operated a patient many years ago with a monofocal, and now he comes to me with a multifocal option for a multifocal. I planned the presbyopic multifocal phakic IOL in these patients. Now, the primary cases where you go in for a presbyopic IPCL would be any patient above the 45 years of age who has a very strong requirement for not wearing near glasses. You attack one eye first, the non-dominating eye, with the correction for near requirement, with slight 0.25 over correction for near, and you go ahead. Now, these patients will last you good 3 to 4 years, and by the end of 4 to 5 years, when they come back to you for the second eye, you evaluate the eye. If there is no onset of cataract, you can go ahead and correct this eye for that current power with again 0.25 to 0.3 more over correction in this eye, and then this patient is good to go. This is one of our primary presbyopic piggyback IOL patients. Do a gonioscopy, always find out the non-dominating eye first, plan one eye, slight undercorrection in the non-dominating eye, especially if the patient is myopic, and overcorrection for hyperopia if the patient is hyperopic. Evaluate the patient's profession and lifestyle. You can accordingly give the intermediate near correction for these patients. As I said, overcorrect hyperopia for distance and undercorrect myopia for distance to get a beautiful long range of vision in these patients. So as I said, this is one of my favorite uses. I use this piggyback IPCL in my pseudophakic patients who now come back to me for options of putting in lens in these patients. So let us see this video of implanting a primary presbyopic piggyback IOL in these patients. I'm going to jump the video soon as I'm nearly running out of the time. And you see, just implanted like a normal phakic IOL, and there you are. The IOL is inside the eye, and you are ready to go. I'll jump the video fast. Now, key for success is proper patient selection, accurate refraction measurements, proper counseling, a trained staff. So in summary, I would say it's a new promising posterior chamber IOL with full advantages. It's a first biopic diffractive phakic IOL available in the market. It is available with customized toric models along with refractive correction, and it's a systematic surgery. There are a lot of publications available in literature and peer-reviewed journals which say there are promising results as experienced by other surgeons, and it is probably a new zone or a new vertical in our armory where we can now operate patients who have been operated earlier with us with monofocals and give them presbyopic correction along with treating patients with primary presbyopia and taking care of these problems. So I think the phakic IOL lens, presbyopic lens offers new options and a new vertical and a lot of benefit to our patients who are looking for presbyopic corrections. Thank you. Thanks a lot.